promptness, those sorts of things. We're trying to indicate the need for pace, and we do recognise that these things are not easy. Some of them are not easy to achieve. But they're focused around a couple of urgent actions around ambulance capacity and around ED weights, both in Enniskillen indeed and in Londonderry, and then also about undertaking, as Stuart said, audits and evidence to be able to demonstrate the effectiveness of the service, to give the assurance to the public, to patients and staff, to the board and so on, that the service and how it's operating and so on. But appreciating the time, we're very happy to take questions immediately.
Okay, and just I have a couple of other questions, but going to the question you mentioned there in relation to the kind of recommendations. So you talked about the urgent recommendations, fixing ambulances, double weights. I mean, has there been any progress in any of that to date?
Well, I know you have colleagues coming behind me, Chair, who will be able to give you the updated information. I know really good efforts have been made, but I think you'll be able to demonstrate, and colleagues will be able to say, that there's still challenges in it. I know the Trust continue to publish their infographic on their website. It's available to me and to all of you, and it demonstrates some of the challenges that are still being faced. But I know from the commitment made in the recommendations that there's a huge endeavour going on to try to address that matter, but I prefer, Chair, if the Trust would answer the progress on that.
We will ask them that, fair enough. So the Minister made a statement saying that he wouldn't be making any change without evidence, and I mean, we're all clear that we want outcomes for patients to be the way they should be, so that's good that he's not making any change without the evidence. In terms of the evidence and the data that you had available to you with regard to making your recommendations, I mean, can I ask if there was deficits? What type of data did you have? Was it good? Would it allow you to do the work that you were aiming to do?
Yes, I'm happy to answer that, Chair. We had lots of information available to us, which I believe we've made endeavour to demonstrate in the report, particularly experience of patients and their families is well evidenced in the report. Listening to those who have had first-hand experience of the changes was a big part of it. Also, the experience expressed by staff working in the services, both in ED and some of the others in an ambulance and so on. But there was a lot of other data available. We had the protocols available to us that had been developed to guide clinicians and the ambulance service during the changes. We had the information, all of the Trust board minutes and papers that were available to them. We had the infographic I've already referred to and some of the calculations. We had waiting times in EDs. Quite a lot of information. So much so that we certainly felt in a position to make 10 quite significant recommendations out of it. But there was an area that needs work. The Trust fully accepted that, and I understand are working hard to address it. And that was on the matter of clinical outcomes for patients on the pathways. Put simply, what people wanted to know was, if I need to have my appendix removed, and I live in Derrygonley or Rosslea or Enniskillen or Balleek or anywhere else on that pathway, am I every bit as likely to have as good an outcome as someone accessing the emergency surgical service in Altnagelvin if they live in Londonderry or Strabane? And that's information. It is available, but it's tied up in the computer systems and the patient records. And the Trust were able to explain to us that the computer systems they currently have don't readily make that information available to them. It is there, it will be available, but it's going to have to be manually drawn out. But when we talk about clinical outcomes, I mean, these are not complicated outcomes. People want to know, will I stay roughly the same length of time in hospital? Am I any more likely to have an infection or some complication as a result of having my procedure if I've come through these pathways, transferring from Southwest rather than locally in Londonderry, for example? Am I any more likely to spend time in intensive care or in a high dependency unit? Am I any more likely to be readmitted after I've been discharged with some post-discharge complication? People wanted to know, is my outcome, my time in hospital, anything I will experience, is that likely for someone of the same profile as me, age, other health conditions and so on? And if so, if that information was available, what we heard was that would provide a lot of assurance to people that despite the difficult journeys, despite the ambulance transfers and many issues we heard about, distressing and anxious aspects to it, of course there were, but overwhelmingly what people wanted to know, will my outcome be the same?
Just so that I'm clear, you're saying you weren't provided that information.
That's correct, Chair. We wouldn't have that level of information. We spoke with the Trust about it. They do recognise that information is possible to get, but it does require significant manual effort.
And how much of a hindrance was that lack of information to you in doing your work, producing your report and making recommendations?
Of course, I think it would be preferable if you had it available immediately. But I think the important thing is